guys, welcome back to my channel. I am Dr. Amanda Shi. I'm an anesthesiologist and intensivist, and today I want to talk about what it's like working with surgeons as a critical care anesthesiologist. I also wanted to comment that at the end of the video, I will be talking about surgical culture. Yes, a lot of the stuff that is on TV about surgical cultures can actually be seen in real life, and there is something to be said about surgical culture and its challenges, as well as the fact that I actively picked being an anesthesiologist, so I'm actively surrounded by surgical culture when I'm in the operating room, and just kind of like how I work through that personally. In terms of places and situations in which I'm working with surgeons, there are 5 main kind of areas that this happens. So one would be in the operating room, which is the most obvious place, is like, yes, we have to work with our surgeons as anesthesiologists in the operating room. Preoperatively, actually, there's a huge component of that. In the PACU, or the post-anesthesia care unit, so immediately after surgery, we will be working with our surgeons. In the intensive care unit where I work very closely with surgeons, and some of the surgeons are actually my colleagues in the intensive care unit as well. And then finally, in like educational morbidity and mortality type conferences, we will be working together and discussing and learning together certain topics as well. So let's start from the top. Number 1, in the operating room. So this is like the most common or the most obvious place where anesthesiologists or surgeons are working together. In the operating room, what happens is a surgeon prior to that operating room date has a patient who would like to get surgery from them. They book them in the operating room, and the anesthesia team meets them that day of surgery. They come up with a plan. We talk with our surgical colleagues about what their expectations are for the type of case it is. Oftentimes we can anticipate some of the things that the surgeons may encounter just through the patient history or other types of factors or in the medical notes. And we come up with an anesthesia plan to keep a patient safe during their surgery. What's really interesting, I think, about the relationship between surgeons and anesthesiologists in the operating room is that it actually has an influence on patient care and outcomes. So there was a JAMA surgery study that demonstrated that increasing familiarity between the surgeon and anesthesiologist actually improved outcomes for the patients. So it is something that makes a difference in patient care, and it makes sense to me as well, because as I've gone through training at the same place and now work as an attending in the same place, I have almost a decade of experience with some of these surgeons, and knowing both their styles, what the strengths and weaknesses are of both sides, understanding the patient population, understanding the actual surgery itself, comes with time, and also just that time and familiarity with each other makes it a lot easier to be able to work together and speak up and be able to communicate. And so this makes a difference for patients, and I think that that's something that's interesting to think about, because it seems obvious when we're in the operating room that things would be better if you knew each other better or knew each other well. But to have that borne out in the literature that familiarity actually makes a difference is crazy to me. So it must be a big deal, because it's actually been studied and shown to be a real thing. The second area, where it's actually more of the first area in a way, but preoperatively, anesthesiologists oftentimes are part of the pre-op assessment process. Not every single hospital has an anesthesia run pre-op service, but my particular hospital does, and I am directing it. And in the last few years in which I've been directing the service, I have learned a lot about how we can optimize patients for surgery and how to identify which patients may need a little extra attention to be able to get them safely through their procedure. Interestingly, I would say that while our surgical colleagues are really, really good about identifying, oh, this patient appears to be sick, and be able to kind of get the process going for a patient to see certain specialists or get certain testing, there are other nuances and things that anesthesiologists are really attuned to and aware of the literature on how we can improve perioperative outcomes and how we can really balance that risk, right? Because everything we do in medicine is about risk benefit. Do we think that the benefit outweighs the risk by proceeding or not? So one of the things that is most common, I would say, in the pre-op space that I see that we have to have a discussion about is a patient who has had a recent cardiac stent. So a heart stent usually requires that you're on an antiplatelet agent, 2 antiplatelet agents, and those agents typically need to be held for surgery. So there's a certain amount of time a patient needs to be on these medications, and that's something that we have to discuss with our cardiology colleagues, our surgical colleagues, and be able to come up with a plan that makes the most sense for a patient. It's really easy for us to say, easy in a way, but easy for us to say in an elective case that we should just not bother stopping it until it's the right time. But in certain circumstances, there's time sensitivity to it. So no one wants to sit around with cancer growing in their body without addressing it and going to surgery, especially if that's going to be a curative thing. But we have to balance that, because if someone's had a recent cardiac stent, they may be at risk for having a heart attack around surgery. So that's something that we talk to our surgeons about ahead of time, and we work with other subspecialists to be able to come up with the safest plan for a patient moving forward. Another thing that I have been seeing more and more of lately too are patients with various implanted devices. So it's not new to us to be able to manage pacemakers and ICDs or implanted cardiac defibrillators. But we now have devices like a hypoglossal nerve stimulator or the Inspire device for obstructive sleep apnea. We have insulin pumps, especially for our type 1 diabetics. That has been something that we've had to manage and be able to come up with a safe plan for these patients, because around surgery, these patients are at risk for going into DKA or diabetic ketoacidosis. And so these are some of the things that I've been exposed to and been part of the conversations with our surgeons on how to plan to safely get a patient to the surgical date. And if you're a patient and you are gonna have surgery and anesthesia is the reason that you keep needing to do these things, just remember that the goal is to be able to figure out the risk that you are taking on by going into the surgery. It is not to delay your surgery. Our goal is not to delay surgery. Most of the time, we want you to be able to get surgery, but we want to be able to also have an idea of how safe it is for the surgical procedure to proceed. The third area where we are working very closely with our surgeons is the PACU, which is the post-anesthesia care unit. So most patients will be going there. There's some patients that go to the ICU, and that's my number 4 place. And in the post-anesthesia care unit, we're overseeing some of the immediate post-op issues that come up. So post-op nausea vomiting is a pretty common one. Depending on the patient or the type of surgery, they might need some medicines to keep their blood pressure up. We call vasoactive agents. Those types of things we would manage in there. Pain is another issue that comes up in the PACU. And sometimes I would say that there's complications that arise like immediately post-operatively. Things like bleeding can happen almost immediately post-operatively. And so we are monitoring for things like that and in constant communication with our surgical colleagues to assess the patient and be able to come up with a plan. So if it's something like a patient that has refractory post-op nausea vomiting, we might say that that patient may not be safe to go home yet because they haven't been able to tolerate a PO or any kind of like food or solid or liquid intake, and that may not be the right patient to send home. Other things that like more severe complications like severe bleeding, that's something where it's really important for us to be in communication with our surgical colleagues, because while I can use medications and I can give blood, I cannot fix the underlying bleeding problem. So that's something where I would need a surgical colleague to come and take this patient back to an operating room to be able to fix the underlying problem. So there's a lot of communication in the PACU space with our surgical colleagues and working together to make sure that we can care for the patient in this next phase of their surgical journey. The fourth place that I would interact with surgeons, though not every anesthesiologist is also an intensivist, I got another year of training to be able to work in the ICU as the ICU attending. I've actually been asked before, oh, do you just provide anesthesia in the ICU? And I had to explain that, no, I'm actually the ICU doctor. I'm the one that's rounding with the team, coming up with the plan, coordinating things, et cetera, et cetera. So in the ICU, I work in a surgical ICU predominantly. I have another couple of other units I work in that are mixed surgical and medical. There's another unit that's mostly medical. And then actually tomorrow I picked up some work that's in, again, a mixed medical surgical ICU, but in a community setting. So in the setting of a surgical patient, there is an interesting thing about the ownership of it. So the surgical patient is typically it makes sense that they're owned in a way by their surgeon, because the surgeon brought the patient to us, the surgeon operated on them. But at the end of the day, as the intensivist, we are focused on making sure every system is cared for and addressed, and that we're supporting every single organ system of the patient that needs to be in the ICU. So if they have ICU needs, that could be things like they're at high risk for some sort of neurologic complication, and we need to check their neurostatus, meaning we do like a neuro exam and like ask patients like stick their tongue out, shrug their shoulders, like move their legs around, move their toes, all those types of things, very frequently to identify if one of those complications were to occur postoperatively. Other things like some patients are just extraordinarily sick and need additional medications to support their body. Like one example is patients with severe heart failure that are getting a bigger surgery, oftentimes need some blood pressure support postoperatively, and sometimes need like aggressive diuresis if there are issues with volume overload, et cetera, et cetera. So those types of patients are a lot of the patients that I'm caring for. And it's really important in the ICU, especially, to be in pretty constant communication with our surgical colleagues. Now, there are patients that will come through that are almost like we call pathway, like we know what to expect. The surgery went really well, the patient is recovering really well, there's not a lot of additional stuff we're doing, and we kind of let that process play out. But there are a lot of situations where it is not pathway, and we have to make some tough decisions. And those are the times where, yes, in the middle of the night when I'm caring for a surgical patient, I may need to call the surgical attending and have a discussion about what we're gonna do next and how we're going to manage a patient. Sometimes that actually means that the surgeon has to come back into the hospital and bring the patient back to the operating room. So that has happened before, but it is, again, this is when we're working together to be able to care for a patient, is also in the ICU. The fifth area that we are working together is in kind of morbidity, mortality conferences, or just like educational conferences. So one thing when I took over the pre-op service is I realized that there are certain medications that can be dangerous in the perioperative period if they're continued. For those of you that are curious, our Ozempics and Wegovy's, like our GLP-1 receptor agonists, those types of medications can increase the risk of aspiration because these patients still have like a full stomach, even if they adhere to our standard NPO or fasting time. And so those types of drugs have caused a lot of challenges in management in the perioperative period, and there have been a lot of changes in the way we manage it over the last couple of years since they've been introduced and gained popularity. So that's one area where I have gone to surgical services to give a lecture about what these medications are, what is the data showing that they actually increase your risk of a full stomach, and then what are we doing right now? Like what evidence is there to be able to try to mitigate that risk, so that the surgeons are also aware and can be part of that process of preparing a patient for surgery safely. So that's one area where like I will go and do a little like educational tour with the different surgical services and answer questions. And then oftentimes I get really great feedback from my surgical colleagues about implementation of these things, because I love thinking about like operations and how do we make things more efficient and how do we care for patients so that they get the best possible outcome and safe outcome as well. So that's one area. The other thing too is morbidity, mortality conferences. So at the end of the day, we still do these. I think they're really important and they're really educational for us to be able to reflect upon what had happened, like what are the actual facts of a situation that has happened, and what are the contributing factors from a systems or human factor standpoint that led to this outcome. And so we will do combined morbidity, mortality types of conferences where there is a patient where there's like an outcome, for example, in the ICU. We'll invite the surgeon over so the surgeon can explain, okay, this, and this happened. Our nurses are also there, so the bedside nurses caring for these patients can provide some of that perspective of what they encountered and what types of resistors or challenges we faced when we were there caring for the patient, et cetera, et cetera. So these are opportunities for us to think about at a system level, what can we do to improve what we do, and are there interventions that we can do so that certain types of things would never happen again, that they turn into a never event. So morbidity, mortality conferences, educational conferences, that's another area that I interact with my surgical colleagues as an anesthesiologist. So the last thing I wanted to touch upon at least is that the surgical culture. What I'll say is, my brother actually just started his clinical rotations, and he started his first day in the SICU, and he 100% encountered the hierarchical, challenging surgical culture on his first day. And one of his questions to me was like, how do you put up with this? And what's interesting is if you don't know or you haven't seen on like a TV show about surgeons, surgical culture involves a lot of toxicity. There's yelling and bullying and hierarchy and just this general sense of like fear and walking on eggshells. Like that exists in surgical culture. To say that I chose anesthesia because I want to be around this is not true. I definitely didn't. I would say I chose anesthesia because the operating room is an extraordinarily special place. There's nothing like it in the hospital. And there's nothing like coming up with the perfect anesthetic for your patient. I mean, I'd say that there's no such thing as perfect, but like the optimal anesthetic for a patient where you keep them safe and comfortable and you titrate your pain medications to the right amount and they wake up and they're not vomiting and they feel good. I mean, I think that is so satisfying, and there is no other place in the hospital where I can do this type of work for a patient and be able to, you know, also work in an environment like the operating room. That's kind of like big picture. Like I picked anesthesia because it is like no other, and it allows for a practice that cannot really be done anywhere else. But as part of that, there's always a downside to every single choice you make, right? There's no such thing as the perfect job. And one of the downsides can be that I will work with different kinds of personalities and work within certain types of cultures. I would say that over the time that I've been in medical training, I've seen improvement in that culture. I've seen changes. I've also seen that, you know, there are little peaks, there's little areas where it still definitely exists, but it's nowhere near as bad as it used to be. And that's not to excuse the culture itself. Like that's not something that I would ever say is a good thing. The culture is not a good thing if it's toxic, but to be able to see the evolution of it improve and change and all of that, I think is really hopeful. It gives me hope. And I think that in the next couple of generations, we might see a more significant evolution of that culture. And so I would say that overall, what I've found is over the years, as I've gotten to know certain surgeons and their personalities, it has made working with them a lot easier. That doesn't mean that it feels good though when there is someone yelling. Even though it's not directed at us, there can be yelling in the operating room that just makes everyone feel kind of on eggshells or on edge or like they can't speak up. And that's where it can be unsafe at times, but it is a more rare occurrence now than way back when. And I would say that like in general, over the time that I've been in the field of anesthesia, I haven't encountered it that much. It's still a rare thing. I would say it's usually incited by some sort of surgical either complication or some sort of challenge that is going on in the surgical field rather than just out of nowhere or that being the norm where someone is acting up. So I'd say that overall, it's not that bad, but it can be very jarring when you first encounter a surgical culture that can be toxic. So yeah, I will say in medical school, I do remember the hierarchy one time of going to like a conference or going to like an educational session and being told as a medical student, I can't sit at the table because that's where the senior residents sit. You have to go sit on the wall, like out at the edge over there. Like you are not a member of this team. You are not respected. Like that type of thing. I'm like, oh my God, like seriously. But I never encountered that kind of again after I left that rotation. So I would say it's really dependent on almost the like local culture that's set up too. And the same thing goes in surgical culture. Like not every single surgical specialty acts in a similar way. There's actually different flavors of surgeons and different flavors, like those different specialties really do lead to different kind of cultures in the operating room as well. So I just wanted to comment on that. I think that's really the elephant in the room that people are asking about when they ask what it's like to work with surgeons. Overall, I'd say I enjoy working with surgeons. I have a lot of respect for my surgical colleagues. And I think when you build that mutual respect, it really goes a long way to providing great care and to feeling like you're working in a really well-oiled machine in terms of a team and being able to almost like orchestrate like a beautiful concert in a way when we're caring for patients. So overall, I'd say clearly I'm still here. I still love my job. I enjoy working with my surgical colleagues, and I have so much respect for them. So it's a great job, and I'd say that I wouldn't be deterred by the fact that we are working with different specialties and surgeons if you're considering a career or a path in anesthesia. But there's obviously ups and downs to every single specialty that exists. Okay, I hope that this was a useful video and content that you enjoy. So if you would like to hear more from me, please subscribe and hit the bell or something I'm supposed to say. And if you want to hear more from me, obviously go ahead and do that. Thanks for listening, and I'll see you guys next time.